Good day, everyone. Today we will discuss about antineoplastic agents, biologic response modifiers. To start with, let us first discuss what antineoplastic agent is. So the antineoplastic agents or anti-cancer drugs represent a large and diverse class of medications. They generally have limited but important uses and often have significant hepatotoxicity. What is biologic response modifiers? Biologic response modifiers, or BRMS, are a class of pharmacologic agents used to enhance the body's immune system or another group of immunostimulants or monoclonal antibodies considered targeted therapy agents. Recombinant DNA and hybridoma technology are two advances that have led to commercial mass production of biologic response modifiers. Interferons, colony stimulating factors, interleukins, and monoclonal antibodies are some currently known biologic response modifiers. With the exception of monoclonal antibodies, biologic response modifiers are complex proteins produced by the cells of the immune system. Individuals taking biologic response modifiers are immunocompromised and should be counseled on concurrent drug and herb use. The three functions of biologic response modifier are first, to enhance host immunologic function or immunomodulation, to destroy or interfere with tumor activities or cytotoxic or cytostatic effects, and lastly is to promote differentiation of stem cells or other biologic effects. And for the pathophysiology of biologic response modifiers, biologic response modifiers modulate the immune response by either interfering with the effect of these cytokines, inhibiting the co-stimulation of T cell activation, depleting or inhibiting B cells. The immune system recognizes and protects the body from foreign invaders such as bacteria or viruses. It also destroys damaged, diseased, or abnormal cells, including cancer cells. When the body detects an invader, an immune response is triggered, and substances such as white blood cells and natural killer cells provide a certain level of protection. Biologic response modifiers, also called immunotherapies, are a class of pharmacologic drugs used to enhance, direct, or restore the body's immune system. Biologic response modifiers consist of substances naturally made in the body and those developed in the laboratory. They can kill cancer cells directly or indirectly. In normal cells, genes regulate growth, maturity, and death of the cells. Genetic changes can occur at many levels. There could be a gain or loss of entire chromosomes or a single point mutation affecting a single DNA nucleotide. Just like the picture, as we can see, a plasmid or a ring of DNA is isolated from a bacterium, then the enzyme cuts the DNA at specific sites. Then a gene for protein taken from another cell is cut with same enzyme and the gene is inserted into the plasmid where it fits exactly. This is recombinant DNA. And the recombinant plasmid is inserted back into the bacterium, and when the bacterium divides and replicates, it copies itself and the recombinant DNA. It resulted in the new gene directs the bacterium to make new protein products such as interferon. Indirect therapies stimulate the body's immune system and do not directly target cancer cells. Biologic therapies are used to treat the cancer or the side effects caused by other cancer treatments. Recombinant DNA, the genetic engineering process that combines two human DNA strands artificially, and hybridoma technology, the process that genetically makes monoclonal antibodies, are two advances that have led to commercial mass production of biologic response modifiers. So when we say biologic response modifier, like other forms of cancer treatment, immunotherapies can cause a number of side effects. These side effects can vary widely from patient to patient. Biologic response modifiers may cause flu-like symptoms including fever, chills, nausea, and appetite loss. Rashes or swelling may develop at the site where they are injected. Blood pressure may also be affected, usually decreasing it. Fatigue is another common side effect of biologic response modifiers. Side effects of colony-stimulating factors may include bone pain, fatigue, fever, and appetite loss. So the classification of biologic response modifiers include interferons, colony-stimulating factors, interleukins, and monoclonal antibodies. First, we will discuss what interferons are. Interferons are a family of naturally occurring proteins that were first discovered in the 1950s. Three major types of interferons have been identified: alpha A interferon, beta B interferon, and gamma interferon. Each type is produced by a different cell within the immune system. All three types can be manufactured using recombinant DNA technology. Type 1 interferons include interferon alpha and interferon beta, which bind selectively to either alpha or beta cell surface receptors on effector cells. Interferon gamma is a type 2 interferon and binds to a different cell surface receptor. Common to both types 1 and 2 interferons and their abilities are to first, regulate the immune system to improve resistance to invading microorganisms, and 2, reduce cell proliferation. However, each interferon group has a specific functionality as well. So what is interferon alpha? This interferon has been shown to have antiviral, anti-proliferative, and immunomodulatory effects, which means that interferon alpha inhibits intracellular replication of viral DNA, interferes with tumor cell growth, and enhances natural killer cell activity. Recombinant interferon alpha is manufactured as roferon alpha and intron alpha. As recombinant interferon alpha is manufactured as roferon alpha and intron alpha, roferon alpha is used in the treatment of first, hairy cell leukemia, chronic myelogenous leukemia, and AIDS-related Kaposi's sarcoma. Intron alpha is used in the treatment of first, malignant melanoma, hairy cell leukemia, follicular non-Hodgkin's lymphoma, AIDS-related Kaposi's sarcoma, and non-malignant chronic hepatitis B and C, and condylomata acuminata. Clinically, interferon alpha has been used to treat non-Hodgkin's lymphoma or intermediate grade, cutaneous T-cell lymphoma, multiple myeloma, renal cell carcinoma, bladder cancer, and carcinoid or a type of cancer-like disease. Intravesical administration of interferon alpha has been proved successful for low-grade bladder tumors. Intraperitoneal administration of interferon alpha has been used to treat ovarian cancer. Intralesional application of interferon alpha has been used to treat melanoma and basal cell carcinoma. Now let's move on to interferon beta. Interferon beta is indicated for the treatment of multiple sclerosis and enhances the activity of suppressor T cells, reduces the production of pro-inflammatory cytokines, reduces antigen presentation, and inhibits the movement of lymphocytes in the central nervous system. While the interferon gamma is indicated for delaying time to disease progression in patients with severe malignant osteopetrosis, reducing the frequency and severity of serious infections related to chronic granulomatous disease, treating patients with chronic myelogenous leukemia and renal cell carcinoma. Malignant osteopetrosis is a congenital disorder hallmarked by two characteristic defects: a defect in osteoclast that causes bone overgrowth, and a defect in phagocyte oxidative metabolism, which can be improved with interferon gamma 1 beta. So the pharmacokinetics of interferon alpha is metabolized by the liver and filtered by the kidneys. However, the body absorbs approximately 80% of the dose. Peak serum concentration are reached 4 to 8 hours after administration. Interferon alpha can be administered subcutaneously, intramuscularly, and intravenously. Although subcutaneous and intramuscular are the preferred routes of administration, subcutaneous administration is recommended for patients with platelet counts below 50,000. So for the side effects and adverse reaction, three major side effects of interferon alpha is a flu-like syndrome. Other effects occur in the gastrointestinal, urologic, cardiopulmonary, renal, hepatic, hematologic, and dermatologic systems. The flu-like syndrome is characterized by chills, fever, fatigue, malaise, and myalgias or muscle aches. Chills can occur 3 to 6 hours after interferon alpha administration and may progress to rigors. A fever as high as 101 degree Fahrenheit to 104 degree Fahrenheit or 39 degrees Celsius to 40 degrees Celsius may occur within 30 to 90 minutes after the onset of chills and last 24 hours. Fatigue, malaise, and myalgias are cumulative side effects. Fatigue is the dose-limiting toxicity. Example, the side effect that necessitates a decrease in dose or discontinuation of the drug. What is erythropoietin-stimulating agents? Erythropoietin is a glycoprotein produced by the kidney. It stimulates red blood cell production in response to hypoxia or decreased oxygen to body tissues. Specifically, erythropoietin stimulates the division and differentiation of committed red blood cells progenitors or parent cells destined to become circulating red blood cells in the bone marrow. ESAs must be used cautiously and only as indicated because of the increased risk for death and serious cardiovascular events when administered to increase hemoglobin levels to more than 12 grams per deciliter. Erythropoietin-stimulating agents or ESAs include epoetin alpha that includes Procrit and Epogen, and darbepoetin alpha that includes RNAs. Procrit is currently FDA approved for treatment of anemia secondary to chronic renal failure. Zidovudin treated human immunodeficiency virus infections, cancer chemotherapy, and anemia in patients who are undergoing surgery. RNAs is FDA approved for treatment of anemia resulting from chronic renal failure and for use with chemotherapy treatment of non-myeloid malignancies. And now let's proceed in discussing specific medications and prototypes. Let's start with interferons. In this slide, we can see the generic name or brand name of interferon alpha 2A or Roferon A, route and dosage, and the uses and considerations, which is for hairy cell leukemia, chronic myelogenous leukemia, condyloma acuminata, and AIDS-related Kaposi sarcoma. Flu-like symptoms such as fatigue, aches, pain, fever, chills, and headaches may occur. And in this slide is the generic or brand name of interferon alpha 2A or Entron A with its route and dosage. Uses and considerations, which is for hairy cell leukemia, adjuvant to surgical resection of malignant melanoma, follicular non-Hodgkin's lymphoma, condylomata acuminata, AIDS-related Kaposi sarcoma, and chronic hepatitis B and non-A hepatitis. Flu-like symptoms, fatigue, gastrointestinal symptoms such as nausea, vomiting, and diarrhea may occur, and low blood counts. In this slide is the interferon gamma or Actimmune with its routes and dosage, and uses and considerations, which is for chronic granulomatous disease. Flu-like symptoms may occur, and also we have interferon alpha entry or Alpharon N with its routes and dosage. The uses and considerations of Alpharon N are for recurring condylomata acuminata, genital venereal warts, and flu-like symptoms may occur. And for interferon beta or batiseron, its route and dosage reduce number of clinical exacerbations of multiple sclerosis. Adults that is greater than 18 years old, subcutaneous 0.0625 milligrams every other day. The uses and considerations for multiple sclerosis, flu-like symptoms may occur. Pregnancy category C, protein binding, unknown, and half-life 8 minutes to 4.3. Next, we will discuss about epoetin alpha or erythropoietin. So, drug class of erythropoietin is biologic response modifier. The trade names are Epogen, Procrit, and Eprox. So, for box warning, ESAs increase the risk for death when given to target hemoglobin or greater than 12 gram per deciliter in cancer patients. So, for the dosage, in adult modified dose to keep target hemoglobin. In chronic renal failure, 50 to 100 units per kilogram 3 times per week, and for cancer chemotherapy, 15 to 150 units per kilogram 3 times per week or 40,000 units per week. For intravenous dialysis patient or administer at the end of dialysis treatment. Intravenous subcutaneous for non-dialysis and chronic renal failure patients. Intravenous subcutaneous 100 units 3 times per week for 8 weeks in AZT-treated HIV-infected patients. Initial dose to those with EPO or erythropoietin levels 500 milliunits per milliliter unlikely to respond to EPO therapy. Subcutaneous, cancer chemotherapy, and drug-lab food interactions. So the contraindications of erythropoietin are uncontrolled hypertension, hypersensitivity to mammalian cell-derived products, or human albumin. For drug non-known and for labs, increased hematocrit, decreased plasma volume, iron stores need to be monitored and replaced. Patients with serum ferritin. Food is also not known, and for the cautions, pregnancy, lactation, porphyria, safety in children not established, increased mortality and or tumor progression, serious cardiovascular and thromboembolic events if target hemoglobin of 12 grams per deciliter exceeded. The pharmacokinetics of erythropoietin in absorption is subcutaneous or intravenous. Distribution, protein binding is unknown, and metabolism half-life 4 to 13 hours in patients with chronic renal failure, 20% less in those with normal renal function excretion in urine. And the pharmacodynamics of erythropoietin, the IV onset is 7 to 10 days, peak is 2 to 4 weeks, duration is unknown, subcutaneous, onset 7 to 10 days, peak is 5 to 4 hours, and duration is unknown. For therapeutic effects or uses, to treat anemia secondary to chronic renal failure, zidovudine treatment of HIV infections, used in patients with anemia secondary to cancer chemotherapy mode of action, increased production of red blood cells triggered by hypoxia or anemia. And about the side effects of erythropoietin are in sense of well-being, hypertension, arthralgias, nausea, edema, fatigue, injection site reaction, rash, diarrhea, shortness of breath, and the adverse reactions, seizures, hyperkalemia, life-threatening, cerebrovascular accident, and myocardial infarction. And now let's discuss about nursing process patient-centered collaborative care. Biologic response modifiers assessment. Obtain a drug and herbal supplement history from patient. Obtain baseline information about patient's physical status. This should include height, weight, vital signs, laboratory values such as complete blood count, uric acid, electrolytes, blood urea nitrogen, creatinine and liver function test, cardiopulmonary assessment, intake and output, skin assessment, daily activity status like for example, ability to perform activities of daily living and sleep-rest cycle, nutritional status, presence or absence of underlying symptoms of disease, and use of current or past medication and treatment. Assess CBC with filgrastim, pegfilgrastim, sargramostim, and oprelvicin before therapy and biweekly throughout therapy to avoid leukocytosis and thrombocytosis. Assess renal and hepatic function tests in patients with dysfunction like, for example, liver enzymes, bone, and serum creatinine. With erythropoietin stimulating agents, assess hematocrit and hemoglobin, serum ferritin, and serum iron transferrin saturation. Most patients will need supplemental iron. The side levels are more than 100 nanograms per milliliter for serum ferritin and 20% less or more than 20% for serum iron transferrin saturation. Assess blood pressure before start of and especially early in therapy. Obtain baseline data regarding patients' psychosocial status, including educational level, ability and desire to learn, support systems, past coping strategies, presence or absence of emotional difficulties, and self-care abilities. Biologic response modifiers such as fatigue, chills, diarrhea, and weakness. With filgrastim, be alert to change in patients with pre-existing cardiac conditions. With oprelvicin, assist for peripheral edema and impact on cardiopulmonary system. With adelsleukin, assess for signs and symptoms of capillary leak syndrome, including hypotension and respiratory distress. Assess patients' families, caregivers' ability to administer subcutaneous biologic response modifiers. And lastly, determine patients' or families' or caregivers' understanding of biologic response modifiers and related side effects. Biologic response modifiers nursing diagnosis, imbalanced nutrition, less than body requirements related to side effects of biologic response modifier therapy, risk for infection related to side effects of cancer chemotherapy treatments and disease condition, risk for deficient fluid volume related to side effects of cancer therapy, impaired oral mucous membrane skin integrity related to side effects of cancer chemotherapy and disease condition, fatigue related to side effects of biologic response modifier therapy, anxiety related to cancer diagnosis and unknown outcomes of treatment, fear related to cancer diagnosis, risk for caregiver role strain related to cancer diagnosis, treatment, and care responsibilities. Biologic response modifiers planning. Patient and family will verbalize understanding of the importance of reporting biologic response modifier related side effects. Patient and family will demonstrate correct and safe biologic response modifier administration. Patient and family will identify strategies to deal with biologic response modifiers related side effects. Patient will remain free from infection and patient will remain free from hemorrhage. Biologic response modifiers interventions. Monitor patient's temperature at onset of chills. Encourage patient to drink at least 2 liters of fluid a day to promote excretion of cellular breakdown products. Assess need for IV hydration, especially during interferon alpha therapy. Encourage patient to rest when tired and to notify healthcare provider if profound fatigue or anorexia occurs. Administer antiemetics as necessary. Pre-medicate patients with antiemetic and administer it around the clock for 24 hours after biologic response modifier administration to further delay nausea or vomiting. Pre-medicate patient with acetaminophen to reduce chills and fever and with diphenhydramine to reduce nausea. Administer biologic response modifier at bedtime to decrease consequences of fatigue. Cover patient with blankets to promote warmth during chills. Administer prescribe moferadine 25 milligrams to 50 milligrams intravenously to decrease rigors. Consult dietitian, social worker, and physical or occupational therapist as necessary. Provide patient and family the opportunity to discuss effect of biologic response modifier therapy on quality of life. Refer patient and family to financial counselor if reimbursement of biologic response modifier therapy is problematic. Continue with same brand of biologic response modifier and notify healthcare provider if considering changing brand. Remember that palifermin binds with heparin, so if patient has a central line, it must be flushed with normal saline before and after administration of palifermin. Patient teaching general. Explain to patient and family the rationale for biologic response modifier therapy. Explain the frequency and rationale for studies and procedures during biologic response modifiers therapy. Inform patient and family that most biologic response modifier side effects disappear within 72 to 96 hours after discontinuation of therapy. Instruct patients of childbearing age to use contraceptives during biologic response modifier therapy and for 2 years after completion of therapy. Provide patient with information regarding the effects of biologic response modifier related fatigue on ADLS, including sexuality. Explain to patient that concurrent use of herbal products with biologic response modifier therapy is not recommended. Side effects. Advise patient to report episodes of difficulty in concentration, confusion, or somnolence. Report weight loss. Report dyspnea, palpitations, and signs of infection or bleeding. Self-administration. Demonstrate correct drug administration techniques. Provide patient or family or caregiver with written or video instructions regarding biologic response modifier self-administration. Cultural considerations. Obtain an interpreter when necessary. Do not rely on family members who may not fully disclose personal information because of cultural norms. Biologic response modifiers evaluation. Evaluate patient or family or caregiver education strategies by asking them to discuss the potential effect of biologic response modifier therapy on quality of life. Evaluate patient or family or caregiver biologic response modifier administration technique if appropriate. Periodically evaluate patient or family or caregiver management of biologic response modifier related side effects. Patients will have a decreased incidence of infection after autologous bone marrow transplantation. Patient will have decreased incidence of thrombocytopenia after chemotherapy administration. So that's all for biologic response modifiers. Below are our references for our topic. Thank you so much again for listening. I hope you have learned something from the video.